Hello friends, welcome to another video of Pulmonology Read Aloud. Today we'll be talking about spirometry, interpretation and the recent changes in spirometric guidelines. If you're new to this channel, then come back to the channel for more videos related to pulmonology topics, post-graduation related material and more recent updates. Before I start this video, a huge shout out to Prudvi Raj who requested for this video. I hope you have a very good DNB examination and this video helps. So pulmonary function testing or spirometry is something that all of us as pulmonary physicians perform as one of the most common tests of lung function. We use this test to measure the airflow into and out of the lung, and we are assessing not only the volume of air that's entering but also the speed of air. So while lung diseases affect the flow or the speed of air in and out of the lungs or the expansion of the lungs through this maneuvers, this test is basically used as a measure of pattern of change, of affection of various volumes, capacities and variables to measure how the physiology inside the lung has changed. Since guidelines have started accepting spirometry as a part of diagnostic criteria and to meet diagnostic eligibility, a lot of times spirometric interpretation has drifted towards diagnosing a particular abnormality, mostly obstructive versus restrictive, asthma versus COPD, and so on and so forth. So spirometric interpretive strategies and technical standards have undergone a change since we last knew it. First, in 2005, major changes in spirometric technical standards were brought about, but these were changed during the COVID or pre-COVID era to a 2019 statement, which I must say was lost mostly under the layers of managing the COVID disaster. But lot of our spirometries, lot of our machines, lot of our interpretations are still based on the 2005 standards, and so it's important to mention this statement in this document, and I'll be talking about the major changes that it had brought about before I start talking about the latest 2021-22 interpretive strategies for routine lung function tests. In 2019, strict considerations to the way the spirometers are used, the technical standards it has, the accreditation were made. So a lot of handheld devices, portable devices or devices which were not meeting the basic requisites were actually told not to be used. Also, there were new contraindications and indications. So if you are a postgraduate student preparing for your exam, then the tables and the boxes in this 2019 guideline talk about newer indications and contraindication list, which you must go through. We'll be talking about the acceptability and repeatability criteria, the end of expiration criteria, the criteria for withholding time for various medication, and how grading systems and acceptabilities have changed since 2019. In the 2021 document, which we'll be talking about in the latter half of this video, we'll be talking about the reference equations which have now changed, what is defined as normal for a healthy individual, what would be a low level and a high level. We'll be talking about considerations that the guidelines mention over the way nature changes over time and how our lung functions change with our age. the interpretive strategies, the bronchodilator responsiveness testing, which has also been changed, and the interpretive flow chart entry that has also been changed will be discussed in the part 2 of this series. So if you're looking at only interpretation and the way that the flow chart and the guidelines have changed regarding how to assess the report, then you can go to the part 2 of this series, which will be hyperlinked above. So spirometry, basically performance hasn't changed in the way it is performed. We still ask our patient to do a rapid maximal inspiration with a blast of expiration, complete and sudden. He continues to completely expire, and with a lot of coaching and encouragement, we ask him to again take a rapid and maximal inspiration. It's important to mention to you here that although there were a lot of spirometers in the past that used to only assess the expiratory volumes, it's important for us to include spirometers that include both the expiratory as well as the inspiratory flow curves and the expiratory inspiratory volumes. This is a part of the change where spirometers have to meet certain standardizations. When we do that, we assess the flow versus volume or the volume versus time, and the peak expiratory flow further with the flow in the first 25 seconds, the 25 to 75 and 75% of our expiration for the patient to reach the vital capacity or forced vital capacity, and then he inhales back again. As I was saying, there are a few boxes which mention tables, which mention indications and contraindications. So if you are giving an exam, these are really helpful. Generally, we know we use spirometry for diagnosis, but we remember that it is basically to check the physiology, the effect that a disease or disorder has on the physiology of the lungs. We use them for monitoring, and this is even more important because the guidelines mention that repetitive assessments have more value, more worth in patient survival and patient's prognosis than one single value. We use it to assess disability, we use it pre-operatively and for a number of research purposes wherein drugs and their effects on the lungs are assessed. There are a few relative contraindications. Again, you can go through this entire list for the exams, but basically we would avoid to do it in an acute situation like an acute myocardial infarction, a recent surgery, a recent abdominal or eye surgery, chances of rise in intrathoracic intra-abdominal pressure, any patient who's not controlled, uncontrolled hypertension, uncontrolled arrhythmias, and such patients will not be taken up for spirometry relatively. There are strict criteria for addressing calibration and standard of the spirometer before actually interpreting the test. Lately, there were a lot of spirometers who would claim to be not using or not requiring any calibration, but the guidelines have really strictly laid down that all spirometers must be calibrated, and this is important to be done daily with a daily log. And once you do that, you can assure that the readings and the values are more accurate. There's a list of activities that should be avoided before doing a lung function testing, such as heavy exercise, heavy meals, smoking, or consuming intoxicants. And there's also a list or table of withholding times for bronchodilator. It's been mentioned that especially when you use LABAs or ultra LABAs, you may have to wait for 24 to 36 hours before you perform a spirometric test. In case you're not able to withhold that long, it has to be mentioned in the spirometry report and interpreted accordingly, but all efforts should be made to perform spirometry after adequate withholding times. 2019 standards also talk about a newer definition of end of expiratory or forced expiration criteria. So in 2005, when the technical standards for spirometry were released, it was said that the patient should be made to expire for at least 6 seconds before he is asked to take a maximal breath in. A lot of spirometers would not accept a reading as not being a part of acceptable criteria if this requirement was not met. In 2019, a major change came where they recommended that instead of going for a cutoff of 6 seconds, we would accept a reading if the patient is able to achieve an expiratory plateau. So this expiratory plateau is more important as compared to the 6-second cutoff. For certain patients, in case they are not able to get an expiratory plateau, like patients with severe air trapping and COPD, but they have been expiring for around 15 seconds, we can ask the patient to take a breath again in and not wait for the plateau to appear. The third criteria of acceptability is where the FVC is within the repeatability tolerance. You've repeated the test and almost every time it is of the same value, then you can meet the end of expiration criteria and conclude the test. Also, it's important now to assess both FVC as well as FEV1 maneuvers for individual acceptance and for between maneuver acceptance criteria. Also, from the acceptable criteria, we do not take an average of the readings, but rather the largest FVC and the largest FEV1 can be taken, or from other indices we can take the largest sum, and this can be accepted for interpretation. What is considered as a standard grading? If you use more than 3 acceptable maneuvers which are within 150 mils of each other, that is a grade A of standardization, and so this spirometry will be accepted with grade A. In case there are more than 2 acceptable criteria with again the same repeatability index, then they can also be accepted with grade B. We would try to accept all readings which are preferably between a grade A and grade B to know whether we have performed the right maneuver techniques. Coming to the 2021 published in 22 ERS interpretative strategies, this also underwent a lot of changes, but majorly 3 main areas underwent a classical change. One was regarding the reference equations, which were the GLI or Global Lung Initiative equations. 2 was the Z score, and 3 bronchodilator response. Let's see what changes have been done in these 3 parameters. So GLI equations were, since all of you know that spirometry always compares a patient's result with any reference value which is taken as normal, the upper limit and the lower limit of normal. So the equations selected for those are called reference equations. It has been seen that there are numerous kinds of reference equations which are used inconsistently among spirometers globally. There is the enhanced 3 data which gives us the values in a normal population as upper and lower limit. There are Polgar data, there is a Quanger data. So the GLI initiative was meant to get a multi-ethnic and multi-racial reference value for spirometry, which could be used for both children and adults. So data for 3 to 95 years old patient range was taken from healthy population, and a lot of cultural and ethnic races were also included to make it one big wholesome set of reference equations. They took over 160,000 data points and used 33 countries who shared their data with the European Respiratory Society, and from that data these equations were produced. So it was mentioned that these patients are quite consistent and they would be one single suite of PFT equations which will avoid any discordance, and it will include the largest samples of healthy individuals. However, one pitfall that has been seen is that despite its name, still the GLI equations have not been able to capture data from many countries and many races. For example, from the Southeast Asian population, from the Indian subcontinent, there have been less data, and specifically pediatric data has been very spare. And what the society or the recommendation society did was that for all those countries where they did not get a good data, they actually derived data by taking an average out of the sum of the rest of the reference populations. So based on this data, they gave 5 main categories as the white population, the black population, the Southeast Asian, Northeast Asian, and multi-ethnic. And what all couldn't be included in these countries, average of everything was put in multi-ethnic, including the Indian and South African countries, and this data was used as a multi-ethnic to be selected while performing pulmonary function tests. Now this is a huge problem, and the guideline statement accepts that although they have tried to give one reference equation, there is pitfall, they need more data. So for countries who do have their own reference populations, like for India instance, we luckily have our reference equation by a very revered professor, Dr. S.K. Chabra, which were published in 2014. So we use those equations. Similarly, other countries who have good, validated, robust equations can still use their equations. But GLI equation does have one particular subset for them, although these may not be adopted universally, and there are a lot of studies which have claimed that their populations equations are not matching with the recommended GLI. Nevertheless, GLI equations have tried to give one consolidated equation, but it's also to be remembered that with age amongst patients, the same value of normalcy may change without any morbidity. So what may be the ratio of FEV1 and FVC for a patient at the age of 36 years, at the age of 70 years, his ratio may normally be low. So this variation with weight, with the age, and this variation with certain special considerations like pregnancy and postpartum period have not been met by GLI equation, and in future we may need more and more reference equations in addition to this guideline. Here we can beautifully see in this example that if we select one cutoff or one standard of 80% or 0.7%, 70% for calling a person's ratio as normal or abnormal, then the same person who at the age of 20 years will have a FEV1 of 3 and above as the lower limit of normal will have a normal lower limit of just 1.5 or 2 at the age of 85 years. So this age gap cannot be met if we are using fixed cutoffs. And how the GLI reference equations might help is that instead of using these cutoffs, we could use better lower limit of normals. So having considered these lower limit of normal comes the very important concept introduced by this guideline, which is of the Z-score. If you look at the normal distribution of data in any healthy population, then majority of the population will come under the peak of the curve. And this percentile, this population is the one which is expected to have normal within normal results. Any deviation from this to the right or the left denies a lesser chance for the patient to have normal results, and this is called as the standard deviation. From the standard deviation is estimated using the Z-score, and the Z-score basically implies what chance a person has that his result will fall within the distribution of normal healthy individual. Similar to the Z-score, previously as well, in the growth chart for pediatric population, in the osteoporosis score using the T-scoring, we have used standard deviation to define what is normal and abnormal. So with the 2021 interpretive guideline, we are trying to do the same for pulmonary function test, and rightly so. So any Z-score which is less than the 5th percentile, or which coincides with minus 1.645, and lower will be abnormal, and anything above that would be normal. So the consensus task force says that the percentile limits, or the Z-score, or the standard deviation method, is a better method to have an unbiased approach to identify values which are outside the expected range. So the use of lower limit of normal, or the 5th percentile, or the Z-score would be a better cutoff to define results which are abnormal, as compared to the fixed cutoffs as in the 2005 statement. So we would no longer be using the percentage predicted values to define normal and abnormal. We would no longer be using the percentage predicted FEV1 of 70% and above, or 60 to 40%, 40 to 35, and so on. We would no longer be dividing FEV1 and FVC ratios as mild, moderate, severe, and very severe, but from 2021 guidelines, we would be determining the Z-score severity to ascertain if a patient has a normal score or an abnormal score. The only problem here would be that there will still be a zone of uncertainty in patients where the lung development was affected, where the healthy normal curve is not achieved, and in these diseased populations there may be one area where the range of value will not represent the ideal lung growth, and in these places neither the cutoffs nor the 5th percentile would be used as an absolute diagnostic criteria, because there will be a risk of considerable overlap in the range of values. And this group of population, especially patients with COPD who had early life exposures or environmental influence which affected the lung growth, the use of percentiles may still not be the most adequate. A very good example to show how cutoffs do not work is this chart. If you look here, then 70% FEV1 FVC predicted falls in the lower limit of normal only at the age of 40 years, which is a good age to screen for COPD for that matter. But as this patient's age advances and he reaches beyond 60 and 80, his lower limit of normal is not 70%, it's much lower. So if you use a cutoff of 70%, you may actually be over-diagnosing COPD in a lot of these populations. And if you use the percentile or low limit of normal, you may still be accurate in your results. Look further close. A male at 10 years has a lower limit of FEV1 81. At the age of 25, the same person has a lower limit of normal 80, and at the age of 80 years, his lower limit of normal changes to 69.4. So use of lower limit of normal, use of percentiles and standard deviations are better to ascertain his lung function decline as compared to a fixed cutoff value. So Z-score tries to eliminate a lot of problems that are coming out of the variations in the sex, age, height, ancestral grouping, because it is looking at multi-ethnic normal distribution amongst the various races. However, it does state the degree of lung function impairment, and it can determine the limit of normality. And this is much more consistent across ages and sexes than a percentage predicted value. So Z-score is the way that interpretation should be done from now on. This is the Z-score severity of lung function impairment criteria. This is a very important slide. Z-scores less than 1.645, so minus 1.645 and more will be normal. Anything between minus 1.65 and minus 2.5 will be mildly affected, minus 2.5 and 4 will be moderate, and less than 4.1 is severe. So this is a very important slide. You can take a screenshot, and when you report PFTs next, look at the Z-scores, and anyone who's more than minus 1.645 is above the 5th percentile, and that value should be normal. A very good example given in the guideline statement, it compares the earlier mild, moderate, severe and very severe criteria with the Z-score and the lower limit of normal application. If you look at it, a lot of patients who were earlier designated as mild impairment are actually normal. If you look at the lower limit of normal, patients who had a moderate to severe diagnosis are actually on the milder curve. Patients who were diagnosed as severe and very severe, if you look at minus 2.5 to minus 4 Z-score, these patients have a moderate affection. And so there is a change in their diagnosis and there is a change in the PFT interpretation based on the new scoring method. This is a very good summary of the changes between 2005 and 2021 technical standard. Let's talk about the first part which we are including in this video. So in 2005, PFT interpretation was used to make clinical diagnosis and decision, but now we are clear that it's more about the physiology and not about the clinical diagnosis, and we are also emphasizing on the lower limit of normal. Earlier, the reference equations were race-specific, ethnic-specific, too many reference equations, different in US, different in Europe, different across the world. But now they recommend to use GLI, although, as we discussed, there are some pitfalls still in the GLI, but they recommend to use GLI for spirometry, lung volume, and DLCO. And the emphasis is on the uncertainty and still incomplete understanding amongst the race and ethnicity. Also, the normal range has changed. So from the general use of lower limit of normal, 5th percentile, but a fixed ratio of less than 70% and less than 80%, we have changed that, and now we would still use lower limit of normal 5th percentile, upper limit of normal 95th. We will not use a fixed ratio and to define normalcy. And another major change is in bronchodilator response. We'll be doing an example of this in the next video. But earlier, whenever we looked at post bronchodilatory values, a cutoff of more than 12% change in FEV1 or FVC and 200 ml was taken as a bronchodilator response, and there was a fixed dose criteria of 4 doses of 100 micrograms salbutamol and waiting for 15 minutes. The 2021 guidelines take away that, and they recommend that more than 10% of change from the predicted value, the predicted lower limit of normal, if it changes 10%, then that's a good response, and there hasn't been any specification on choice or protocol for bronchodilator according to the recent guideline. Coming quickly to what is the bronchodilator response then, the ATS-ERS 2005 statement spoke of 200 ml and 12%, but this has changed. And the changes that we have to look at the changes in FEV1 and FVC, and we should express bronchodilator responsiveness relative to this patient's predicted lower limit of normal. So, any change more than 10% from the predicted normal will be a positive response. So, this has to be strictly an increase relative to the predicted value so that you can minimize other variables that affect the bronchodilator response. And normally, bronchodilator and FVC would be more indicative of air trapping as compared to FEV1. Also, very important is to take home the message that the ability of a response to bronchodilator to predict future clinical status is not clear. So, we cannot say that this patient, because is a bronchodilator responsive patient, will be performing better. And 2, it does not differentiate between types of airway disease. So, responsiveness akin to asthma, no responsiveness akin to COPD, this concept has to be changed, and we have to remember that it may not be so. So this is really emphasized in this guideline. This is how we calculate bronchodilator responsiveness. We take the post-bronchodilator value, the lower limit, minus the pre-bronchodilator value upon the predicted value and multiply by 100. We'll be doing this example in our next video with a spirometry report. And this is an example given. If the post bronchodilator was 2.4 and the pre was 2 and you expected the lower limit of normal as 3.32, then this patient will have 12% change in bronchodilator response, which is a significant response. Two more concepts. One is the natural changes over time. We know that lung function will change over time, and patients more than 25 years will have a 30 mil decline every year. So in two populations, the elderly and the children, there is more scope of change in the reference. So here two approaches are identified. One is something called a conditional change score for children, and the other is FEV1Q for adults. So in children, because the lung functions are more variable, especially in rapid growth in adolescence, they recommend that a conditional score can help us assess the limits of reproducibility of the lung function. This is how the change score is defined. It's still not well studied and is proposed as a way of identifying the change. And here the Z score of FEV1 at a point of time T1 and T2 and the observed FEV1 at that point of time is considered with a constant, and these changes are considered as a change score. So for example, if there is a child and his lung function drops from say one Z score value to another Z score value within 3 months, we can calculate a change score. Normally change score should change within 1.96, but if this change is more than 1.96, that means it is not according to his age variation and this patient has some or the other medical issue. For adults, FEV1Q has been proposed. You may hear more of this value. So FEV1Q again basically is an approach where we divide the FEV1 by the sex-specific first percentile value of the absolute FEV1 found in adults with lung disease. So there's this constant 0.4 liters in women and 0.5 liters in men. You consider their sex-specific percentile value and then you divide it and you get a result called FEV1Q, which in normal circumstances a unit of FEV1Q is lost every 18 years, so it almost stays stable if you look at the age and the sex of the person, and about every 10 years in smokers and elderly it will change. If this FEV1Q is changing more frequently than that, then it means that there's a precipitous change in lung function, and this can gauge meaningful changes over a period of time. This is how we calculate FEV1Q. So for a 70-year-old woman with a FEV1 of 0.9 liter, you divide 0.9 by the female constant 0.4 or 2.25. Any value closer to 1 indicates a major change, so a greater risk of death. So this is again a proposed criteria. There are a lot of pros and cons, but in future we may see some applicability of FEV1Q. In fact, Z scores have certain problems in elderly individuals, and many elderly individuals can be classified as severe because of Z scores. So FEV1Q may help us there, and it may be better in elderlies and predict a better survival index. Lastly, touching upon the trend graph, the recent guidelines mention that it's important to consider an absolute change in FEV1 over time. So a visual representation of serial measurements may be included in your PFT reports, and that decline reflects the real change in lung function. This is to show an example. This is actually much recently I changed and upgraded my spirometer to the new standards, and now I get reports which give me a Z score, a Z score or a Z score, and It also gives me the variation of the score in a graphical format, and this is a trend graph. So just like many other lab values, now we are getting a trend. What was this patient's, where was the z-score prior, and what is the z-score now, so we can compare whether there is any change. So this is a good addition in lung function test reporting. So having said that, we complete the first part of this spirometric interpretation series. In the next video, we're talking about the 2021 interpretive strategy. We'll take an example, we'll apply the new standards, we'll check the z-score and the bronchodilator responsiveness in this, and there are certain new examples given in the guidelines to reflect the flow volume curves. There are also new terminology in addition to obstructive, restrictive and mixed, which we will be talking about. So join me in the next video. Happy reading and bye bye.